CLL management. اتفضل يا فندم.
First of all, I'd like to thank the organizing committee for allowing me to attend this excellent scientific meeting, the 6th Delta Hematology Conference. So I'd like to thank Dr. Isam Abdel Mohsen, Dr. Sabri, Dr. Ala Atif for inviting me and for their effort to arrange this meeting. And I feel unlucky to miss the previous 5 meetings actually. My talk today will be focused on the frontline management of CLL. As you all know that CLL is one of the most common lymphoid malignancies. It's originally the disease of elderly, and more than 60 to 7% of patients are above the age of 65 and presented with different comorbidities. Actually, I will start the talk with this algorithm. When you are facing a newly diagnosed patient with CLL, candidate to start treatment according to the International Working Group CLL criteria. First of all, we focused on the age of the patients, the comorbidities, the performance status, and the biology of the disease regarding if this patient harboring any mutations like TP53 mutations or deletion 17p according to the FISH analysis, or IGHV mutation status. So for the patients presented without deletion 17p or TP53 mutation by FISH and NGS, and the IGHV mutated, and the patient is fit and the age is less than 65 years, and the GFR more than 70 milli per minute, or series less than 6. So these patients are young, fit, and mutated without deletion 17. These patients can get benefit from the chemoimmunotherapy or other molecules like the ibrutinib, venetoclax plus opentuzumab, or acalabrutinib plus or minus opentuzumab. If the same patients have the IGHV mutation and unfit or has a high series, this patient will be a candidate for bendamustine, rituximab, or ibrutinib, venetoclax plus opentuzumab plus or acalabrutinib plus or minus opentuzumab. For those patients with IGHV unmutation, don't waste your time with the chemotherapy for these patients, because this patient is not responding to the chemotherapy. So this patient should have ibrutinib or venetoclax plus opentuzumab, or acala plus or minus opentuzumab. For the patients with deletion 17p or TP53 mutations and high risk, so these patients also have a resistance to the chemoimmunotherapy, so the patient will get benefit from only ibrutinib, venetoclax plus opentuzumab, or acala plus or minus opentuzumab. There is some consideration regarding the comorbidity for the patient. If the patient has a history of cardiac arrhythmias and receiving anticoagulation therapy, or difficult to control hypertension, consider acalabrutinib or venetoclax before ibrutinib. Patients with bulky disease and diminished creatinine clearance and high risk tumor burden, consider ibrutinib or acalabrutinib before venetoclax. So this is the algorithm for the different patients with newly diagnosed patient with CLL. Here is the prognostic value of the FISH analysis for the patients. As you can see from this curve, that patients harboring the deletion 17p mutation have the worst prognosis comparing with the normal karyotyping or other deletion like 13q deletion. Also, the impact of TP53 mutations and TP53 deletions on the overall survival. And patients presented with TP53 mutation and deletion have the worst outcome comparing with the TP53 wild type. This is the historical data regarding the chemoimmunotherapy and survival by the IGHVStatus. The patients with IGHV mutations and young fit patients, these patients will get benefit from the FCR, and the data from MD Anderson they have a follow-up for more than 12 years, and more than 90% of the patients have overall survival, more than 90% for patients receiving FCR for this cohort of patients. Also, in the aerial study and the CLL unmutated IGHV associated with much shorter median overall survival. Patients with IGHV unmutated have 95 months, and patients presented with mutation have 293 months. This is the key first line CLL clinical trials. We have many trials addressing the frontline therapy for the newly diagnosed patients with CLL, and the chemotherapy standard protocols. We have the FCR for the young fit patients. We have the bendamustine rituximab for elderly patients, elderly fit patients, and the Gazyva chlorambucil for elderly and unfit patients. And there are different studies addressing the frontline therapy, comparing the chemoimmunotherapy with the PTKIs and the anti-BCL2, and all of the study they concluded that the outcome in the term of progression-free survival and overall survival with patients receiving the PTKIs plus anti-CD20 better than patients receiving chemoimmunotherapy alone. So I will start to discuss this study, the CLL11. It's a study of addressing the obinutuzumab plus chlorambucil as a first-line therapy for patients with coexisting conditions or comorbidity. The study design randomized patients into 3 arms, arm receiving obinutuzumab plus chlorambucil, and arm chlorambucil alone, and other arm rituximab plus chlorambucil. The stage 1A comparing obinutuzumab chlorambucil versus chlorambucil, and stage 1B comparing our chlorambucil versus chlorambucil alone. The primary endpoints were the progression-free survival by investigator assessment, and the second endpoints were the IRC progression-free survivals and the best overall response and the overall survival and duration of response. This is the baseline characteristic for different cohort of patients, and as you can see, the patient characteristics were equally divided between the different group regarding the age, the performance status, the CIRS score, and the staging system, also the risk stratifications by the unmutations IGHV or deletion 17B by FISH. The progression-free survival data showed that patients receiving Gazyva chlorambucil showed a median progression-free survival around 98.9 months, while patients receiving rituximab chlorambucil showed a progression-free survival 15.7 months during the median observation time around 6 months. Also, patients with the subgroup analysis were in favor of the Gazyva chlorambucil in different subgroup analysis regarding the age, sex, the series scoring, or the risk stratification by staging or FISH technique. All of this subgroup analysis were in favor of Gazyva chlorambucil in the term of progression-free survival. How about the minimal residual disease in the CLL11? The MRD negativity in the peripheral blood or the bone marrow at the end of treatment were more common in Gazyva chlorambucil. Actually, patients with MRD negative response in the peripheral blood where and the MRD negativity rate in the peripheral blood were 35.8% in the Gazyva chlorambucil arm, comparing with 3.3% in the rituximab chlorambucil arm. And MRD negativity rate in the bone marrow were 18% in Gazyva chlorambucil, comparing with 2.6% in rituximab chlorambucil arm. So the progression-free survival, according to the MRD negativity at end of therapy in the peripheral blood, patients achieved the MRD negativity as the top level, the blue line in the curve showed that the patients showed a progression-free survival, the median progression-free survival around 50%, while patients receive MRD intermediate showed progression-free survival 23%, and MRD positive and the peripheral blood showed 13.9% progression-free survival. Also, the time to next treatment, the patients with Gazyva and chlorambucil shows time to next treatment around 49 months, around 56 months, comparing with the 34 months in the rituximab and chlorambucil, and with the reduced risk of progression by around the 42 months. Also, the median overall survival was not reached in the Gazyva chlorambucil arm, and reached equal around 37 months in the rituximab and chlorambucil. Also, the overall survival in the Gazyva chlorambucil were better comparing with the rituximab and chlorambucil in all subgroup analysis. Regarding the adverse events, actually there was no safety signals detected. The more than grade 1 adverse event were more with the Gazyva chlorambucil, but most of the adverse event were hematologic adverse event, and it was reversible. And the grade 3 to 4 adverse events were around 74% in the Gazyva chlorambucil, comparing with the 51% in the chlorambucil. Also, the serious adverse event were 47% in the Gazyva chlorambucil, comparing with the 39% in the chlorambucil. Also, the grade 5 fatal adverse events was 8% in the Gazyva chlorambucil, comparing with the 11% in the chlorambucil arm, actually it's due to the disease progression. Also, the second malignancy were 5% in the Gazyva chlorambucil, comparing with 1% in the chlorambucil arm. Also, the all deaths was 39 in Gazyva chlorambucil, comparing with the 49 in the chlorambucil arm. The main cause of death were adverse event 10% in Gazyva chlorambucil and 15% in the chlorambucil arm, and disease progression were 5 in the Gazyva chlorambucil, comparing with 2 in the chlorambucil arm. So the conclusion from this study, after a median observation of 5 years, Gazyva chlorambucil maintained an acceptable and manageable safety profile, Gazyva-chlorambucil provided a clinically meaningful improvement in progression-free survival and overall survival versus chlorambucil, 79% reduction in the risk of progression of the disease or death, and 39% reduction in the risk of death, versus rituximab chlorambucil, 51% reduction in the risk of progression of the disease or death, and 24% reduction in the risk of death. So the Gazyva-chlorambucil prolong the time to next treatment relative to R-chlorambucil by 1 to 1.5 years, attaining an absolute treatment-free duration of 4 years. So this combination, the Gazyva and chlorambucil, was FDA approved as a class 1 for the treatment of elderly patients with comorbidity, the CLL. But actually, recently, the other study, the Illuminati study, which is addressing combination of emtricitabine plus ibrutinib in the elderly patients with CLL, the patients receiving ibrutinib plus emtricitabine and the other patient receiving chlorambucil, other group of patients receiving chlorambucil and emtricitabine, the primary endpoint was progression-free survival. And the second endpoint was the progression-free survival in the high-risk patients and MRD negativity, overall response rate, and overall survival. So the Illuminati study showed that progression-free survival in the intention to treat populations, and the emtricitabine was not reached the median progression-free survival, while in the chlorambucil emtricitabine was around 19 months. So after this study, the combination of emtricitabine and ibrutinib became the class 1 for the patients, elderly patient with comorbidity, and the Gazyva-chlorambucil actually تراجع انه بقى class 1A. The other study, the CLL-14, it's addressing the fixed duration first line approach for the CLL, which is comparing the two arms, the one arm receiving emtricitabine for 6 cycles and venetoclax for 12 cycles. Venetoclax starting on the day 22 from the cycle 1 by 20 milligram, and every week ramping up the dose till they reach 400 milligram orally on day 1 on the cycle 3. And the other arm receiving chlorambucil and emtricitabine. The primary endpoints were the progression-free survival by investigator assessment, and the second endpoint was the overall response rate, the MRD negativity, and overall survival. Also, the patient characteristics were equal between the two arms regarding the age, sex, the staging risk, or the risk stratifications by the TP53 mutations or IGHV mutations. The progression-free survival by investigator assessment showed that the group of patients receiving venetoclax and emtricitabine have the progression-free survival around 81 months, comparing with the 49 months for the patient receiving Gazyva and chlorambucil. Also, the 4-year follow-up, the progression-free survival, median progression-free survival with the venetoclax and emtricitabine was not reached, while it was 36 months in the chlorambucil and emtricitabine. And 4-year progression-free survival rate in the venetoclax emtricitabine arm was 74%, comparing with the 35% in the chlorambucil and emtricitabine. Also, the progression-free survival by TP53 mutations actually compared with the Gazyva chlorambucil, the progression-free survival benefit was observed with the venetoclax Gazyva, irrespective of the TP53 deletions and or mutations. There was no difference or the presence of the TP53 mutations in the term of progression-free survival assessments. Also, the IGHV mutations compared with the Gazyva chlorambucil, the progression-free survival benefit was observed with venetoclax and Gazyva irrespective of the IGHV status. And time to next treatment, the risk of starting a new line of treatment was reduced with venetoclax and Gazyva compared with chlorambucil and Gazyva. Also, the 4-year follow-up time to next treatment, the median time to next treatment with venetoclax and obinutuzumab was not reached, while also in the chlorambucil obinutuzumab was not reached, and 4 years time to next treatment rate was 81% in the venetoclax obinutuzumab versus 59% in the chlorambucil and obinutuzumab. And next anti-leukemic therapy was venetoclax obinutuzumab was 35 progression of the disease only, while in the obinutuzumab chlorambucil was at 122 progression of the disease. Also, the overall and complete response rate was significantly higher with venetoclax Gazyva than with chlorambucil and Gazyva. It was 84% in the venetoclax Gazyva versus 71% in the chlorambucil and Gazyva. Regarding the MRD negativity, the MRD negativity with less than 10 power of 6 was 42 in the venetoclax obinutuzumab, comparing with the 7% in the chlorambucil and obinutuzumab. And MRD status more than 10 power of 6 and less than 10 power of 5 was 26 in the venetoclax obinutuzumab and 13% in the chlorambucil and obinutuzumab. So the MRD negativity with less than 10 power minus 4 with venetoclax and obinutuzumab occurred early and was durable. Also, the MRD negativity was sustained. It started early and it was sustained all through the study in the arm of venetoclax and obinutuzumab comparing with the chlorambucil arm. As you can see, after the assessment, after the 3 months, where more than 70% MRD negativity in the chlorambucil venetoclax arm, while in the chlorambucil obinutuzumab was around 35% only. So there is an early response regarding the MRD negativity and sustained in the venetoclax arm. So the conclusion from this study that the CLL14 study established the efficacy of this combination, venetoclax and diagnose patients with CLL with comorbidities. The fixed duration targeted treatment with venetoclax and obinutuzumab resulted in a significantly higher percentage of patients with BFS than standard treatment with chlorambucil and obinutuzumab. Longer follow-up is necessary to assess the durability of response. And I think I finished this slide. Thank you very much.